we, in our practice, manage medications. So for the first half, I'm going to concentrate on my experience at St. Michael's Hospital and our approach to pre-transplant medication management, and then pass it over to June, and she will cover what she sees kind of peri and post-op. So yeah, I shouldn't take more than about 15-20 minutes to go through my slides, and then I'll hand it over. If you have any questions, I believe you can type in your questions, but obviously at the end we'll have a lot of time. We're hoping to leave a lot of time for Q&A at the end. So just a little bit of our objectives and outline. I'm going to cover two main concepts or topics. I'm going to go through some of the drug-related pre-transplant prep that we do at St. Mike's to prepare our own patients or patients that come in from other clinics or even other provinces. I'll also spend some time outlining one of the most probably time-consuming from a pharmacist standpoint and most interesting topics is the dosing and management of the antibiotics used pre-transplant. In those two topics, I'm going to cover current status, some of the resources we use, and really some kind of thoughts for the future, dealing with kind of areas of quality improvement where some collaboration potential can come about. So a little bit about myself. For some of those who don't know me, I've been a pharmacist at St. Michael's Hospital for almost 17 years, 16 years I think, but I've been with the CF program since 2005 and have had the opportunity to work with Dr. Tullis and the team really for more than 10 years now, and it's been a great experience to work in that team. So I'm going to just jump right in terms of the journey in the pre-transplant side of things. So the way I would foresee it as that part of the journey is a patient will be assessed, typically referred from a CF clinic and assessed by Toronto General. But if these patients were not followed by St. Michael's in the Toronto Adult Clinic, we typically will see them in our clinics just as a touch base point right at the beginning during the week of assessment at Toronto General. But it isn't till the actual relocation of that patient to Toronto or when they're truly listed does the pharmacist at the St. Mike's team get involved. So we might know about a patient being assessed, but it's not till listing that we're pretty much brought into their care. And right from the get-go, we are involved in trying to look at the history of their chronic medication and looking at what medications we want to continue and maintain, and if there's any room for optimization, we're working with our team to improve any of the chronic medication management. Some of the issues we deal with in our assessment at St. Mike's from the pharmacy standpoint is we do a comprehensive drug history. So we'll look at any medication lists or information that is shared with us from other clinics. And from there, transitioning to the actual relocation, what sort of gaps could there be in their medication management? Things like making sure that the right medication list comes over to us, knowing where they're going to be getting their meds dispensed from. So that's where we start to get involved truly in the beginning stages to do with drug access and coverage. So what we often do is, if the patient wasn't followed by us, we would be reaching out to the referring clinic and asking what sort of drug access and coverage have you worked on? So the clinic coordinator or the pharmacist there may have intimate knowledge of the type of issues with their private plans or the public plans. Obviously, we will sit down with the patient and try to get as much information from them, but there are times where obviously they rely on you as clinicians in their home clinic to pass all that information over to us. And while we try to work through some of the drug access problems, one of the main issues we find is dealing with that in more of a high-stakes setting where we're dealing with an exacerbation. So this is where a patient deteriorates while they're waiting for their transplant, while they're listed, and it's during that time where we obviously want to ensure they're on the best IV antibiotic regimen as possible. This is where we want to look back truly to see what antibiotic regimens they've tried in the past, what doses were used, and any kind of circumstances revolving around their acute exacerbation care that we can use to our advantage when we're treating exacerbations leading into transplant. So I kind of alluded to this already. So the pharmacist at St. Mike's, so that's myself, and just about 2-3 years ago now, we were joined by another pharmacist, Kevin Curley, who we both jointly work on the respirology ward, and we oversee the CF patients both as an inpatient. So we have an inpatient pharmacist and a clinic or ambulatory clinic pharmacist. So we split our time, and we have a presence on both sides, so to speak. And the ward pharmacist will closely monitor the hospitalization, the use of the IV antibiotics with exacerbation, and look at what chronic therapies need to be continued on discharge while they're still waiting on the transplant list. And also, in the event that we want to be able to send them home on home IV antibiotics, we want to ensure that they have the right access available. So if they're a patient that lives in Ontario, we utilize the access points available to us in this province. But if you're coming from out of province, we have to kind of look at what do we need to know from the home province in terms of coverage to ensure that these patients can continue on antibiotics in their location while they wait in Toronto. If there are any follow-up needed and the patient continues on IV antibiotics, the clinic pharmacist kind of picks up the baton from there, and they ensure that the optimization of everything they need while they're waiting in Toronto is taken care of. And we, on a daily basis, touch base and work together on the care of these patients. Now, one thing to note is clinically we work up on the respirology ward, but we have a very close relationship with our outpatient pharmacy. As you can imagine, as patients are changing their medication therapy, it requires us to be in touch with our outpatient pharmacy, which is called the Prescription Care Center. But they are a separate team. We rely on them to kind of tell us the needs from a drug access and coverage standpoint, and we relate to them some of the clinical needs, ensuring that they're on the right chronic CF medication regimen, which IV antibiotics need to be dispensed from them or which need to be dispensed through an admixture pharmacy. I've provided you with some contact information here, and the reason being is we think that if a patient is coming from another area and may be dealing with other pharmacies normally, it's nice for our outpatient pharmacy to be in touch with theirs and vice versa to ensure that transition of the medications they need while they're waiting is optimized. And I've already touched on this quite a bit already. Our pharmacy team will ensure that their chronic medications, their IV antibiotics, and even the nursing and supplies are taken care of. And this is particularly the case for patients out of province who are coming into Ontario. Because we can't utilize our internal provincial community access points, the pharmacist typically is the point person in our team. So we're the ones trying to figure out what kind of coverage that province provides in terms of IV supplies, what kind of nursing care is provided. And we'll talk to the referring clinicians. We'll also sometimes talk to the government officials that oversee the drug program. You can imagine, too, there's a lot of paperwork involved regarding getting authorization, whether it be for a private plan or a public plan. The pharmacist on our team is typically responsible for filling these out and ensuring that there's communication to all stakeholders. And then finally, as we know, in CF care, a lot of times patients are utilizing more than 2 or 3 pharmacies at a time. And again, as the pharmacist on the team, we are kind of held responsible to ensure that all the points are talking. So this is typically like specialty pharmacies that provide specialty medications like some of the newer inhaled antibiotics or some of the modulator therapies. We also have the regular local pharmacy, but then we have the admixture pharmacies, the ones that provide the IV antibiotics in the home care setting. And we become that point person so that if any of those pharmacies have questions and the patient's unable to answer that, then we provide our information so that they can talk to someone within the CF care team. So that's kind of the first part of what I wanted to speak to, kind of what we deal with currently on the pre-transplant side, and some of the reasonable asks that a pharmacy team member will often make of other clinicians. So we want a good medication history list to do with the chronic medications. But now I'm going to kind of shift over to the acute exacerbation side of things and deal with one of the truly complicated parts of CF care is the IV antibiotics for an exacerbation. And quickly, I'm just going to break it up into dealing a little bit with pharmacokinetics and pharmacodynamics specific to cystic fibrosis, and then spend some time specifically on antibiotic dosing and the approach that we use. And I'm going to concentrate more on the IV antibiotics. I'm going to ignore the chronic medications, although we do have resources that we can share to talk about dosing for inhaled antibiotics, let's say. And I'm going to briefly go through some of the dosing and issues that we think about when we're picking IV antibiotics and how we dose them and how we monitor them. So for my colleagues out there who work in cystic fibrosis, we know that CF patients go through medications differently. And one of the easy ways to kind of look at this is when you look at pharmacokinetics, it's how the body deals with the drug. And in case of a cystic fibrosis patient, there's 2 main areas that they deal with drugs differently. So one would be the absorption, because the cystic fibrosis gut is different than a normal gut. There is chance for delayed absorption. Now, does that mean that not all of the drug gets absorbed? Not necessarily, but it takes longer for that drug to get into the system, and we have to recognize that sometimes. The more important part is really just how the CF patient clears the drug. And so we know that a CF patient has enhanced clearance compared to the regular population. What that means is anything that's cleared by the kidneys will be cleared faster and more so than in a regular patient. So when we're dosing antibiotics, if we know this antibiotic is cleared by the kidneys, we automatically have to think of how can we optimize that dose and increase that dose in a safe way and monitor it in a safe way. Now, pharmacodynamics is kind of the flip side of that coin, and this is how the drug affects the body, or anything in the body. So when we think of how the drug affects what it's trying to treat, what we're concerned about is, do we have the right amount of drug to kill the bacteria in the lung? And if we know that that bacteria is resistant, well, what does that mean? What kind of concentrations of the drug do we need to overcome that resistance? So things like the minimum inhibitory concentration, or MIC, is important to us. We need to consider that when we're starting to target the serum levels of a certain drug like tobramycin. We also have to consider, do we get enough of that antibiotic into the lung, into the place where the bacteria are living? And that's essentially just ensuring that we have the right drug concentration in the sputum. Now, we know that systemically we can get as much antibiotic as we can and have optimal doses, but this is where we use inhaled antibiotics to its advantage. It gets the antibiotic to the site of where the infection resides, and we get to treat it topically almost right where the sputum lies. The other components of pharmacodynamics really revolves around some of the bad problems of drugs, so the drug interactions, how the drugs will interfere with each other, sometimes in terms of the absorption, or interfere with each other in terms of how the body metabolizes the drug. And as the pharmacist on the team, we have to be on the ball, kind of proactively looking at any drug interactions that may occur with the antibiotics, or dealing with any interactions that we see right away and clinically treating them. And then finally, the adverse events and drug allergies, which I'll delve into a little bit more shortly. So I want to highlight a series that was developed in 2013 by our colleagues in Utah. Dr. Zobel and Dr. Young and colleagues created an optimization series looking at anti-pseudomonal antibiotics for cystic fibrosis pulmonary exacerbation, specifically for Pseudomonas treatment. And in this 5-part series, they looked at 5 main classes of antibiotics used for anti-pseudomonal antibiotics. But it's important to kind of recognize the limitations of this. So although we wanted to look at trials specifically in cystic fibrosis, it's important to have a control group. And most of the studies we looked at didn't have enough control outside of the CF population. We also realized in the studies that were collected in this series, there wasn't a lot of information that helped us know that if an antibiotic was susceptible to an organism, would that relate to proper clinical outcomes? We just didn't have that data, and it was very hard to find studies to do with that. But fortunately, in that 5-part series, they summarized all of their findings. So they looked through pharmacokinetic literature, pharmacodynamic literature, and they summarized every anti-pseudomonal antibiotic that was studied in CF. And what you see here is Table 4 from Part 6 of that series. It summarizes the doses for all the anti-pseudomonal antibiotics that were studied and the maximum doses. So this is to ensure that we're treating aggressively in an exacerbation and ensuring what is the safest limit of antibiotic dosing we can use. But from this, again, this is a systematic review, essentially, that puts together information from so much literature. Is this really practical? When I read through this, it isn't necessarily. So we've had to boil this down to a list that is obviously practical and usable in the clinic setting and in the hospital setting. And what you see here is us boiling this down to practically how do we start a patient empirically. If we're going to start someone on, let's say, Astranam, we typically start them on 2 grams IV Q8H, but in an aggressive dosing or in a more critical patient, we do have room to move up and go as high as Q6. Interestingly, Astranam, out of all of these anti-pseudomonals, requires federal access. So through the Health Canada Special Access Program, we have to acquire that in from outside of Canada so that we can use it in our setting. And it's important to know is if this has been used previously prior to transplant, it's nice to share, and pharmacists have a knack of sharing our templates with special access drugs. It's good to kind of see what literature was used in the previous submissions, what clinical information was provided at that time, and we share that information so that if the next hospital needs or the next pharmacist requires assistance filling out this paperwork, we can pass that information on. I want to also take the moment to highlight the last antibiotic you see here. So for tobramycin, there's a lot of talk about how to best use tobramycin in a pre-transplant setting. And even though I list it here and the dosing is here, and we talk about following therapeutic drug monitoring quite closely, this is one of the antibiotics because of the risk of renal dysfunction post-transplant. We sometimes hesitantly look at this and say, maybe we won't use this if we don't have to. So often, when we look back at CF guidelines that say you must use a beta-lactam and an aminoglycoside to treat a pulmonary exacerbation, the pre-transplant population is one of those populations where you may not want to use tobramycin right away to spare the kidneys the insult of the aminoglycoside, so that post-transplant there may not be as much complication. And there's quite a bit of literature starting to be worked on at improving the way we monitor tobramycin. So not just looking at peaks and troughs, that is the conventional way of dosing tobramycin and monitoring. We're looking at things like area under the curve and cumulative doses that will give us a better understanding of which patients in the CF population have just had too much tobramycin and that we should spare them from using this too much. Now, rather than go through all the details of the side effects here, as you can see, some of the quick things to just make note. The beta-lactams and the monobactams all affect LFTs, so we monitor their liver function tests quite carefully. But all of these antibiotics are not immune to adverse events, and it is important to monitor that in the pre-transplant stage, but it's also important to get that information from referring clinics. If there is information about intolerances or these side effects that have occurred previously, we want to obviously know that. The same can be said of the patients that we refer here in Toronto to the transplant team. We pass on this sort of information. If we know that the colistin causes peripheral neuropathy in this specific patient, we will pass that information on to our colleagues at Toronto General and let the pharmacists know there to watch out for these things, and that there could be ways to mitigate those side effects, like changing the dose and splitting it up into more frequent dosing throughout the day, or even just slowing the infusion time. Now, this list here goes through the antibiotics that we would use for the non-Pseudomonas groups. We don't currently have any systematic review or literature that allows us to see what is the best dosing for antibiotics used for Burkholderia cepacia, for Stenotrophomonas. So we're kind of left in the pharmacy community to really just look at what is the optimal dosing in other infections, and looking at what are the highest doses that can be used. So rather than going into the detail here, you'll see here that we provided a list of the typical empiric starting doses of these antibiotics. And you'll see some of these are the ones used for MRSA, like doxycycline, linezolid, Septra, and vancomycin. Many of the other ones are used for cepacia. The last two antibiotics are the newer ones. Ceftolozane tazobactam is a relatively new antibiotic, which we don't have a lot of experience with here in Canada, just recently marketed, but we're seeing evidence in the phase 3 trials to do with pulmonary infections that the dosing that's in our monograph is actually lower. So the monograph will say 1.5 grams Q8, but we've doubled that dose. Again, because CF patients will clear this drug faster, we suspect that using a better dose to penetrate the lung is more appropriate in the CF population. That last antibiotic you see on this list is ceftaz-avibactam. We've only used it once in Toronto, and again, based on the monograph that we have from Europe, this is the dose that we know of, but we suspect that in time when we learn more about ceftaz-avibactam, we might have to increase the dose of this as well. This is another special access drug not available in Canada and requires paperwork as well. And then, kind of to finish this section off, I've put a list of all the adverse events that we would typically monitor for in the inpatient and outpatient setting. Truly, there's a long laundry list of adverse events, the common ones and the not so common ones and rare ones that we watch for. Obviously, we are one of the best on the team to help counsel and educate patients on how to mitigate the risks that we see with much of these antibiotics we use to treat. So what I want to kind of end off on is to speak to what exactly in our practice do we see as the best that we do, and where can we make some improvements. And one of the things I can definitely look at how we practice is that we don't currently have a standardized way of sharing information about the medications that we use to the transplant team. So my colleague June, who will be talking to you shortly, is one of those colleagues that could benefit from having a very detailed medication list, the history of all the antibiotics that were used, let's say in the last 2 years, and the regimens that were used, how long they were used, and any of the adverse events or therapeutic drug monitoring issues that we've encountered. And sharing that with them will obviously allow them to manage any post-op infections and really get a sense of how that patient responds to therapy. So that's one of the areas that, even in providing this talk, we definitely hold ourselves accountable to. We have a means, or we have room for improvement to share our information with the transplant team. The same can be said to do with medication, drug access, I should say, and drug coverage. We really only share information by exception. So if the transplant team reaches out to us and says, have you ever dealt with this before, or vice versa, we might know this patient has had a hard time getting onto an inhaled antibiotic. We'll share that information proactively. That doesn't happen in a standardized way. And I think that's one of the things we as a team in St. Mike's want to improve on, and would love to partner with other clinics that refer patients to the transplant team on sharing ways to improve that process. If you have room to improve in your own clinic, we might as well have a standardized way to share our information. So in that kind of note, I am sharing our information here. This is how to contact us at St. Michael's. So the inpatient pharmacy, we are a 24/7 operation. You could reach a pharmacist at that phone number and find out about information of any of our inpatients. But to deal with some of our CF patients that are looked after in the ambulatory setting and in the inpatient side, I provided information for myself and Kevin, the 2 pharmacists in our clinic, and finally our drug access navigator, Alana, and her contact information here, and she helps us basically get drug access for all of our CF patients in the best and timely way. So with that, I'm going to pass it on to my colleague June, and I'll leave some time, like I said, at the end to answer any questions you might have. So here's June.
Okay. Hi there. Good afternoon. My name is June, and I'm one of the transplant pharmacists at Toronto General Hospital. Just to give you a couple seconds, a little bit of a blurb about me. I've also been at UHN for about 16 years now, first at the Toronto Western site, but I've been in transplantation since 2008. So I'm very, very fortunate to work with an amazing group of people, Allied Health, of course, the medical team, and about 8 pharmacists. We have a very strong presence on the floor on the inpatient ward, and on top of that we have an ambulatory clinic pharmacist as well. So we work very closely all together. Just a small caveat I just wanted to mention is we are a multi-organ transplant center, as Dr. Chaparro might have mentioned in a previous session. So although, today we're talking about CF, we really do cover transplant for all organs and all lung transplants, a portion of that, which is CF. So we really are quite knowledgeable, I would say, in many areas of transplantation. But today I'm so happy to be invited to be part of this project and can share our expertise in managing your post-lung transplant patient. So just a couple of objectives. I wanted to talk a little bit about anti-rejection meds in the lung transplant recipient. and of course to focus a little bit more on the CF patient as opposed to lung transplant recipient. So we'll talk about the anti-rejection meds and as well as common infections. Daniel gave a great overview, but we'll kind of shift gears a little bit and talk about what happens post-transplant. And finally, what interests a lot of people are the province-specific recommendations for drug reimbursement. That's always a challenge when we have our out-of-province patients coming, to kind of make sure that we can provide the most seamless and comprehensive reimbursement really for that patient, because as we all know, that is a huge stressor for a lot of patients coming to Ontario. So lung transplant recipients are often on 15-plus medications. We're talking about anti-rejection pills and stuff for their other disease states like insulin, bowel routine stuff, anything, heart pills, antidepressants. CF lung transplant recipients are often on even more meds than the typical lung transplant recipient that are related to their CF. For example, their enzymes, GI motility agents, CF-related diabetes, inhaled and systemic antibiotics, and they are just, by the nature of their disease, is at a higher risk of lung infection. The bottom line being, medication regimens can be extremely complex. So the standard protocol post-lung transplant is as follows. Everybody is on a calcineurin inhibitor, usually cyclosporine or tacrolimus, prednisone, and a third anti-rejection agent, an antimetabolite, usually MMF, so either Myfortic or Cellcept, or azathioprine. As a standard protocol, we also have everybody on PJP prophylaxis with Septra double strength. In an allergy, we will consider dapsone or inhaled pentamidine, as well as we have most people on antiviral prophylaxis, so they will get ganciclovir intravenously immediately post-op. We'll transition them to valganciclovir, or Valcyte is the brand name, orally. Or, depending on the CMV or cytomegalovirus donor-recipient serology, they could be on acyclovir. And the duration of therapy is 3 to 9 months post-transplant, depending, again, on that serology and what risk category they fall into for CMV infection. And I'll talk a little bit more about CMV infection in later slides. Lastly, we have everyone on nystatin for 3 months as antifungal or oral thrush prophylaxis. Because a lot of CF patients end up being on a systemic antifungal, we can hold off on the nystatin. They don't need to be on both. So this slide has a lot of information. I just wanted to go over it kind of quickly, but highlight some details about the calcineurin inhibitor that some people may or may not be aware of. So cyclosporine and TAC are taken twice a day, 12 hours apart. Some people might not realize that there are IV formulations of both. So there's an IV formulation of cyclosporine. It is given by slow IV infusion over 2 to 6 hours. The conversion is not one-to-one. So it's really important to know that when you're converting a patient from a PO dose to adjust that properly or convert that properly to the intravenous dose. And tacrolimus IV, there is an IV formulation available, but it's actually not commonly used or recommended because it is given as a continuous IV infusion. So doing trough levels, it makes it really hard to then draw a trough level and interpret that level, and subsequently, what do you do with that level? So we really, really encourage our teams not to go with IV TAC. The immediate release tacrolimus or Prograf can actually be given sublingually or via an enteral tube. So what we often do for patients who can't swallow is open the capsule and put it sublingually, or it can be flushed down a tube, NG or G tube. So those are two good alternatives to giving the medication PO. Taking these agents with the enzymes is really important too in CF patients. Kind of for the reasons Daniel talked about, absorption and that sort of thing. But the key, I think, is to be consistent. I think, we tell that to all our patients, to be consistent with taking all of your meds. But with CF, I think in particular, to get the levels properly, if they are taking it with the enzymes, to always take it with the enzymes. Also, these meds are monitored very closely. We monitor trough levels, and we titrate the dose based on these levels. Now, a question that I often get, or we often get, is what's the target that we're looking for? So I really hesitate from giving a target, a blanket statement, because the target is really individualized and determined by lots of different things, individual things about the patient, such as the time from transplant, their age, what other immune suppression they're on, whether or not they've had any bouts of rejection and what they were treated with for that rejection, kind of looking at their overall immunosuppressive state. So it's really kind of hard to give a blanket statement what that trough is. I'll show you a chart in the next slide that kind of gives you a sense, but really that it's quite individualized. And just at the bottom there, just some points that, we're monitoring blood pressure. The drug can be nephrotoxic and or can cause changes in creatinine or increases in creatinine, so we're watching the creatinine really closely. There's lots of drug interactions with these meds, so we're watching that really closely, and of course lots of adverse effects that we are watching for. This is the table that I was talking about in terms of what kind of maintenance trough levels we're looking for. So you can see that trough, it ranges between 250 to 350 in the immediate post-op state, but tapers down to, we can target a lower trough when they're a year out of transplant. Prednisone, most people are quite familiar with prednisone. Lots of adverse effects, and we always try and taper down to the lowest dose possible. Most patients are maintained on a dose of 0.25 milligrams per kilogram per day. So based on the weight, give an example, we're kind of looking at anywhere between 10 milligrams up to, if they're a bigger person. But in CF, they're usually not a bigger person. So really, the dose we just base on their weight. And the third and last anti-rejection agent we have patients on is an antimetabolite. So that would be mycophenolate in most patients. So there's the myfortic formulation and the CellCept formulation, and I've just written the conversion there. Also note that there is an enteral tube solution formulation or an oral solution for the CellCept. So patients that are immediately post-op, they mostly have a tube in, and they will mostly be on the liquid formulation to start. There is also IV CellCept, and that is something we also do in the hospital, sometimes if the patient requires it, but we will convert them to PO once they're appropriate. Again, I've listed some adverse effects. So diarrhea is the main one that we see, and of course the leukopenia we're watching for as well. I'm just going to mention azathioprine really briefly. We really use azathioprine when they're not able to tolerate the MMF due to GI toxicity or leukopenia, that they just really can't stomach it. Most patients are on the mycophenolate, so I just want to mention there it is an alternative should that be necessary. Another question we get a lot are, do patients have to be on the brand name formulation? So our program has, come up with a statement saying that we do highly recommend the brand name formulation of these immunosuppressive agents. So specifically, cyclosporine, we want them to be on the Neoral brand. Tacrolimus, we want them to be on Prograf. And for the mycophenolate, either myfortic or CellCept are acceptable. The reason is because there's just a little bit of concern, or I guess uncertainty on our end, the program, in that switching between the various products, either brand and generic, generic to brand, could theoretically lead to a fluctuation in levels. And therefore, it could give us unpredictable levels. And that would, in turn, theoretically put them at risk of rejection. For most meds, we all, a lot of pharmacists will know or believe that it really doesn't matter between the brand and generic, and I think I agree, for most things it doesn't. But in the case of immune suppression, where the graft is such an important and scarce resource, and really the transplant is such a scarce commodity, really, to get an organ, we try and minimize any risk we just can't predict the levels necessarily of the generic product at this point in time, so we do recommend the brand name. Now, we do know that the reimbursement of the brand name product may be an issue. For example, even in Ontario, CellCept is not a general benefit under ODB, so we do convert patients to Myfortic. That is a general benefit. Some other things we can do is we write no sub on the prescriptions when we discharge patients. There are cards from the drug companies to help gain access or help patients get access to the medications. But really, the bottom line is try and be consistent. So if the brand is being dispensed and the patient is taking the brand, to keep them on the brand. If for some reason, due to reimbursement or what have you, they have to be on the generic, to keep them on that generic, because that's what the levels are being done according to. Just a small blurb about treatment of rejection. So at any point in time, really, a transplant recipient is at risk of rejection. To treat acute rejection, we usually start with pulse steroids for 3 days, and then 3 days of intravenous steroids, and then prednisone and tapering down to baseline. One thing that we do is maybe consider converting a patient from cyclosporine to tacrolimus. Most patients start on cyclo, but for sometimes patient in specific factors, we just don't get good levels with one and we switch to the other. Another treatment is anti-thymocyclobulin or thymoglobulin, which is a T-cell depleting intravenous agent, quite potent, quite strong. They are in hospital to receive this therapy. If they are on this kind of T-cell depleting agent, we do need to reconsider prophylaxis with things such as an antiviral and PJP prophylaxis and oral thrush prophylaxis. And finally, there are some plasma exchange and IVIG are two other, things we can do to treat rejection. Infection. So as we talked about, cystic fibrosis lung transplant recipients are, I would say, even more susceptible than the average transplant recipient to infection. These patients are more often than not colonized already pre-transplant, and then of course opening them up puts them at risk of further infection, as well as now we're immune suppressing them. So again, that infection risk is quite high and quite significant. One infection we see commonly post-transplant is CMV, or cytomegalovirus. It is a major cause of morbidity in lung transplant. You can see the numbers are there, 39 to 64%. And, there's lots of indirect effects on CMV infection as well. We usually see it shortly after transplantation, so 1 to 4 months post-transplant, and the reason is because that's when someone is most highly immune suppressed. We look at CMV serology, so we look at the donor serology, whether or not they had been exposed to CMV, and the recipient exposure, so whether or not they had been exposed to CMV, and use that to assess the risk of infection. And how we monitor diagnosis is by CMV PCR. I kind of mentioned it, but most patients are on antiviral prophylaxis. The dose is dosed according to renal function, and we use it for prophylaxis as well as for maintenance or treatment. So for prophylaxis and as well as if someone has an infection, for treatment and for further maintenance. We have a CMV protocol that gives us some guidance in terms of dosing, especially dose reduction in renal impairment or dialysis. The biggest side effect is cytopenias, and these agents are actually quite well tolerated. So I'll just mention that. Acyclovir is another potential antiviral we can use. And lastly, I just wanted to quickly mention Foscarnet. We've actually been seeing a lot of it recently. So patients can have CMV resistance in that the ganciclovir or valganciclovir, the virus is resistant to these agents. So Foscarnet is an intravenous agent that is special access, so we do need to apply to Health Canada and get the approval. It is known to be very nephrotoxic, so they are in a hospital receiving pre-hydration, sometimes even pre- and post-hydration, and close monitoring of the creatinine and electrolytes while they're on this therapy. we do send off resistance testing. It has to be sent out to Winnipeg, and we can actually even determine the exact genetic mutations and therefore kind of tailor treatment to it. I just also made a little note of 2 new agents that we're hearing about in development, maribavir and letermovir, that hopefully can give us a few more options in treating CMV. They're still in development, and I have a feeling one of them is due to come out in January, but don't quote me on that. Here's our TGH transplant guidelines for CMV prevention. You can see here that the donor and recipient serology is listed there on the left-hand side, and the doses are listed there as well. So depending, again, like I mentioned, on the serology, we would pick our agents, and the duration is listed there too. So that first category where it's a donor positive, recipient negative, we call that a CMV mismatch, and that is the highest risk of that recipient then getting CMV infection because they have never had exposure and the donor has had exposure. So the prophylaxis duration is 9 months, a bit longer than the other classes of patients. Aspergillus is another infection. So that's a fungal infection that we usually see in a BAL. We can do cultures, and they do a test called galactomannan, and also we look at the clinical picture of the patient. If they have aspergillus, we will usually prophylax them with voriconazole, which I'll talk about on the next slide. Here's just a treatment algorithm that talks about the BAL culture and, you know, the different pathways we can take. Like I mentioned, we usually treat with voriconazole. A really, really important thing for all the pharmacists out there, if you are having anyone start on voriconazole, it's very important to reduce the calcineurin inhibitor by 50%. There is a strong drug interaction, and we just empirically actually reduce the dosage of their anti-rejection cyclosporine TAC by 50%. We also then look at levels of both the calcineurin and as well as the vori, and we're looking for voriconazole levels of between 1 and 5. Amphotericin B inhaled is another option, although I'm told right now it's actually on back order, and the other antifungals, posaconazole and itraconazole, can also be considered. Just a little blurb about the Special Access Program. Daniel touched on that, but there is quite a lot of paperwork necessary if we are starting these agents. So we will work very closely with the medical team to try and get the approval and also coordinate the acquisition and distribution and cost of those things in hospital. So as Trianam is IV special access. Inhaled Casein, which we actually never start in hospital at Toronto General. Most patients that are on Casein or inhaled as Trianam come in on it, and we actually have them use their own supply because we can't even access it here at Toronto General. I think it's obtained through a special program in special pharmacies. IV phoscarnet, I mentioned again, is special access, and other non-licensed agents, I'll just mention cisapride is one of them, is another special access item that we see once in a while, and we try and help medical teams get access to, and the patient. Other complications, I'm just going to breeze through this, but these are other infectious complications that we see post-transplant, both, you know, any transplant and lung transplant. So C. diff, MAC, PTLD, PCP, oral thrush. And of course, other complications, especially in the CF population, all of these things listed. So they're gastric dysmotility, hyperkalemia, hypertension, diabetes, renal function, anemia, osteoporosis, dyslipidemia, EOS, and any anticoagulation they're on. So in addition to now all of their immune suppression that they weren't on before, all of these conditions might be accompanied by medications, and we are trying to really balance a whole slew of things in the post-op period. At Toronto General, we have a great program that we do, a self-medication program, where we teach patients about their new immune suppression agents. It's a 1-hour-long class taught by one of us pharmacists, and patients will take to their room a small supply of these meds and really self-medicate for the duration of their hospital stay, and really that's to get them accustomed to the medications and really the dose adjustments that are required with the anti-rejection meds. We find that CF patients are really quite good and have no issues with compliance. They've really been managing their illness their entire life, but it is still some other populations are not quite as good as CF patients, but it's still a really great program we have. And these are just a sample of the info sheets that we give to patients during the class. So just to kind of shift gears a little bit, I'll stop talking about the clinical and I'll talk a little bit about the logistics in discharging a patient. So what does the inpatient pharmacist do as we're starting to plan a discharge? We work really closely with the medical team. We round with them every day and, of course, deal with any clinical issues that come up. We work really closely with a discharge coordinator. We have a lung transplant discharge coordinator on the inpatient unit, and they are really the point person to coordinate everything about the discharge. We also have a medication reimbursement specialist. Her name is Lucia, who specializes in transplant meds, and we will often call on her to help us navigate any reimbursement needs for that patient, including out-of-province requirements. And we also have our own outpatient pharmacy called Transplant Outpatient Pharmacy, and we work really closely with them as we send the prescription to them, and the patient's meds are dispensed from them. We reconcile all meds on discharge, we generate prescriptions, and we really try to ensure a safe and smooth discharge. Throughout the patient's admission, kind of as meds are being added to their regimen, we are very cognizant of any items requiring special attention. So that could be an EAP or a special auth form. We flag that to the drug reimbursement specialist, and she will give us some guidance in terms of what needs to be done. And then we will then liaise with the medical team to get that paperwork filled out. In Ontario, those of us that are in Ontario will be familiar with Trillium and ODSP and the seniors plan, but here are just some of the meds we use commonly post-transplant that are EAP, so valganciclovir, which I mentioned is most patients are on Valsite for at least 6 to 9 months. Dapsone is an EAP in Ontario, so that requires a special request. Myfortic is general benefit on ODB, but Cellcept is not. Interestingly, it is an LU for other organs, but not for lung transplant. And voriconazole is an LU for aspergillosis. Daniel mentioned it again, touched on it, but what happens if the patient needs antibiotics going home? So in Ontario, we have a community access CCAC that will initiate and coordinate in-home nursing care as well as delivery of those antibiotics to that patient's home. A regional pharmacy will manufacture and dispense the meds. Here in the GTA, it's called Kalia, but it might be different pharmacies in different parts of Ontario. And reimbursement, like any pharmacy, is really based on the ODB formulary, what is covered and what is not. And of course, if a patient has a private drug plan, we will access that as well. So transplant meds are very, very costly. We quote patients up to $5,000 a month. That is an obscene amount of money, and if someone is ill, of course they're not working, so it really can be prohibitive. So we have a lot of work that is done pre-transplant to ensure that things are in place so that this can be manageable. So in addition to oral meds, patients are discharged home sometimes on IV antibiotics that might require nursing care, injections, or inhaled therapies as well. So all of those things need to be looked at as we're planning a discharge. The key point is, for all provinces, including Ontario, to ensure that drug coverage is in place prior to the transplant. There are some people that fall through the cracks and or some people that get sick in a fulminant kind of scenario that don't have drug coverage. And really, when you're recovering from a transplant, you're in the ICU, that is not the time to be arranging, getting a Trillium application, having to send in your taxes for the year previous. So it's really, really important that prior to listing or during the listing, but really prior to being listed, that you have drug coverage in place. So what does that mean? It means registration with your provincial drug plan, if that's applicable to you, and also to ensure that you're, if someone has a private drug plan, to ensure that that is active as well. The only caveat with the private drug plan is each private drug plan has its own formulary. So some things may require special auth, even for that private drug plan. Unfortunately, we have to act a little bit proactively because we can't predict what that patient will be on post-transplant. But we will, of course, as soon as someone is put on that agent, we will check if it needs special auth and go through the steps to get that done. CF patients are fortunate in that we even have a special drugs plan, so that also helps to take care of a lot of things if there's anything, that has fallen through the gaps. So out-of-province patients. So what happens if you're from out-of-province and your transplant is here in Toronto? Immediately following hospital discharge, meds will be prescribed and dispensed in Ontario for at least 3 months. So one of the requirements of transplantation is you do stay in the Toronto area for 3 months after your transplant for the follow-up care. So again, the meds are costly. Most of the anti-rejection meds, there is an agreement and they can be reciprocally billed. So, and what that means is we can bill that directly to the province. Other drugs may or may not be billed. So again, it depends on the plan and depends on the medication. In the chance it can't be billed directly, that patient may need to pay upfront for that agent and await reimbursement from that plan, whether it be a provincial or a private plan. Again, I think a lot of times we get questions about this, but it really will just have to be patient-specific because we can't really predict what that patient will be on until after the surgery has happened and we see their course in hospital. And again, we're looking at PO meds, IV antibiotics, and all the supplies and nursing care associated with those. This is just an internal form I thought I'd throw up here. This is a form that us, the inpatient team, and our medication reimbursement specialists kind of use as a tool to communicate between to each other. You can see that we've listed the province where the patient is from, and we've listed the drugs that the patient is on, and there's a kind of a checklist in terms of Lucia, our specialist, will come back and tell me what category these meds fall into, so whether they are covered by the provincial plan, whether they require special paperwork, whether they're covered by a private plan, and she'll write any notes to us. So we find this really helpful to kind of give us an overview picture of what needs to be done. The kind of bad thing is I can give her the snapshot on this day, but tomorrow if the team adds something, it is a bit of a dialogue kind of throughout that patient's admission because things are happening, all the time. I just wanted to put up here too, what is the best case scenario for an out-of-province patient? We recently had a patient come from British Columbia, and both Daniel and I were able to work with this patient. And we felt that BC Transplant is really, doing such good work in making that process really easy for us here in Ontario to really take care of that patient. So what they did is they sent us a letter. I think both sides got it at St. Mike's and at Toronto General. A letter confirming coverage for all meds. There were no exclusions, no forms needed, so all PO medications, all IV meds, all nursing care. That was even potentially needed post-discharge, and included were specific instructions on where and to whom to send the bill to, which is always nice. This is just that letter. So it really was just earlier this year that we had this happen, and we thought it was wonderful. It just made everything easier and a little more seamless and a little bit less stressful for the patient and for all of us taking care of the patient. Just a couple more slides just about the overall post-discharge care. So a transplant coordinator who is an RN is assigned to every transplant recipient. Our program, I believe, takes care of about 5,000 transplant recipients. Because everyone who's ever had a transplant at Toronto General, we will continue to follow them. So there is a transplant coordinator taking care of that patient, and they really are the best person and for any questions or concerns regarding that outpatient. We get a lot of questions, even about meds and things, but, we are a bit out of the picture now that the patient has left us from an inpatient standpoint. So I think if you had questions about a patient, really find out from that patient who their coordinator is. Get that person's email or what have you, and really I think questions is best directed to them. They can then, if anything, divert or triage that question to anyone else, whether it be that ambulatory pharmacist, or maybe they needed a refill, or maybe they had questions about blood work or tests. Really that coordinator is the person to coordinate all of those things. This is a sample of the type of follow-up that a transplant recipient is really committed to. They are in clinic every week, so that first kind of yellow box there, they're in clinic every week for a really long time. And you can see there's all, different schedules for different things, but the second box I have down there, treadmill or exercise, they're actually at Toronto General 3 times a week. I think it's important to have that expectation that patient doesn't think that once their transplant is done, that they won't be seen, but it's reassuring to know they will be seen quite frequently. I should joke to them that they'll get sick of seeing us, but they're actually here in the building. They have to come to Toronto General, downtown Toronto, 3 times a week for physiotherapy. So that also gives them the opportunity to pick up their meds if needed, book other appointments, and other consults on those days. So lastly, transplant outpatient pharmacy. That is our fully accredited outpatient dispensing or specialty pharmacy. It is the first in Canada, so we're really proud to have this in the building. We work very closely with them. The inpatient team and the outpatient team work very closely together. And as well, we have an ambulatory clinic pharmacist. I put the email on there. So really, any outpatient issues can be directed to this email. It is one of us clinical pharmacists in that role every day. So we do see a wide range of indications for initiating a consult. For example, we can perform a meds check, we can assist with therapeutic drug monitoring, we do a lot of counseling, and we can work with patient compliance, setting up blister packs, those sort of things. They can be referred by the Transplant Coordinator to come see us, or the patient can self-refer. And we are available by appointment as well for face-to-face interactions. And finally, the medication reimbursement specialist I've mentioned is also somebody that is a great resource as well. So finally, in conclusion, between Daniel and myself, we recognize that there are gaps in the current workflow. I mean, even between our 2 programs, which are literally down the street from each other, we sometimes, don't properly or don't communicate to the best that we probably could. And so potentially even more so from external clinics and programs to and from our programs, there are gaps. So improved proactive communication as well as seamless sharing, I think, of medication-related issues and documents can only help to prevent inefficiencies and optimize the patient experience as they transition from pre to post-transplant. And with that, I think we're finished, and I think we'd happily take questions if there are any.
Yes, thank you. So this is Joanna Valsamis from Cystic Fibrosis Canada. I want to thank Daniel and June for your presentations today. And as June mentioned, we're open for questions now. So you can either use the raise the hand feature that you should see, I believe, beside your name on the screen. And if you click that, I can unmute you, and then you can give your question over the call. Or if you'd like to use the Q&A box that's also located at the bottom right of the screen, you can type in any questions that you have there. So I'm not seeing any questions or hands raised. So what I'll do is we can end the webinar here. Again, I want to thank Daniel and June, and just so you know, the webinar has been recorded, and we'll be posting this up on Cystic Fibrosis Canada's website within the next week. As well, if you're interested in joining future webinars, you can take a look at the lineup of speakers and topics on our website under the Healthcare Program tab. So thanks again, and have a great afternoon. Bye.
Bye.